Let's look closely at nerve injuries that lead to specific hand distortions. In normal physiology, the flexors and the extensors will balance each other out. However, when a nerve is disrupted, much of the pathology occurs due to the lumbricals. These peculiar muscles are responsible for doing three things: flexing the MCP joint, extending the DIP-PIP joints, and confusing medical students for decades. What is clawing? Well, it's not exactly this cat. When the median or ulnar nerves are lesioned distally, the remaining normally innervated extrinsic flexors exaggerate the loss of the lumbricals, which is going to cause flexion at the DIP and the PIP joints. The first distortion is called ulnar claw. Loss of the ulnar nerve distally leads to a loss of function in the medial lumbricals and an inability to extend the fingers. When a patient tries to flatten or open their hand, their pinky and ring finger stay clawed, and it creates the Pope's blessing. The key to differentiating an ulnar claw and the Pope's blessing is determining if the patient is trying to open or close their hand, so then you can tell which fingers are dysfunctional. What if, instead of trying to open the hand, the patient were trying to make a fist right now? Then that would be a proximal median nerve lesion. Here, the patient may lose the ability to flex the lateral fingers, so if they tried to flex those fingers, they would appear to be having a similar Pope's blessing appearance. What if your patient is giving you the OK sign? You need to know what they're actually trying to do. If your patient is trying to give you a high five, then extending the fingers to flatten their hands, then it's a distal median nerve lesion. See how the fingers can't extend? And what if the patient is trying to make a fist? It'd be a proximal ulnar nerve lesion. I've always thought that proximal ulnar nerve lesions must be the most frustrating of all the hand lesions. You're trying to make a fist to punch someone, and instead all you can do is give them the OK sign. Does this look like an ape's hand? Maybe not. What if I told you that this person has trouble opposing their thumb? As in, they can't hitchhike because they can't get their thumb to move away from their hand. What muscle isn't working? That would be the opponent's pollicis. What nerve innervates this muscle? The proximal median nerve. Injury of the median nerve at the elbow or wrist takes out the thenar muscle and the opponent's pollicis muscles, which can severely atrophy in these patients and ultimately inhibit hitchhiking. Alright, it's flash quiz time. What lesion would cause this total claw? The answer is lower trunk lesions, C8 and T1, of the brachial plexus. The forearm finger flexors innervated by the median nerve and finger extensors innervated by the radial nerve are unopposed. I just mentioned the thenar muscles and the hypothenar eminence, which are pictured here. What muscles comprise the thenar eminence? The opponent's pollicis, abductor pollicis brevis, and the flexor pollicis brevis. Two briefs and an opponent. Based on what we just talked about with the ape hand, what innervates the thenar eminence muscles? The median nerve. Good. On the other side of the hand, we have the hypothenar eminence. What nerve do you think innervates this collection of muscles? The ulnar nerve. Here, we've got the opponent's digiti minimi, abductor digiti minimi, and the flexor digiti minimi. 3 minimes. Imagine the Austin Powers character, Mini-Me, holding up his pinky finger, using his hypothenar eminence. Now you got it. What do the thenar and the hypothenar eminence do? They oppose, abduct, and flex. Remembering O, A, and F should help you remember both the action and the muscles in each of these regions. 3 more groups of the hand to master, okay? The dorsal interosseous muscles, the palmar interosseous muscles, and the lumbrical muscles. The dorsal interosseous muscles abduct the fingers, or spread the fingers. What about the palmar muscles? They do just the opposite. To keep these straight, use the mnemonic DAB pad. All right, dorsal's abduct and palmar's adduct. Finally, let's do the lumbricals. Do you recall what the lumbricals do? That's right. They flex the MCP joint, extend the PIP, and extend the DIP. Do you remember why they're important? These muscles are accountable for the clawing presentation of the ulnar and medial nerve lesions. And now we have the lower extremity. For step 1, this is likely a lower yield section than the upper extremity. There are fewer types of injuries that you'll be expected to understand, and almost all of them are listed on this page. Do not waste your time understanding the sacral plexus. As we work our way through the chart in first aid, let's just look at all of the nerves. You have the obturator, the femoral, common perineal, also known as the common fibular, tibial, and the superior and inferior gluteal nerves. Notice that the obturator and femoral nerves, both from L2 through L4, are directly off the spinal cord, like the superior gluteal and inferior gluteal nerves. But the tibial and common perineal are actually terminal branches. Do you recall which nerve gives rise to these two nerves? The sciatic nerve. Let's give each of these nerves a little more attention. The obturator nerve innervates the muscles along the medial aspect of the thigh, which are all the muscles responsible for adduction of the thigh. It makes sense that the injuries of the obturator nerve will cause difficulty in thigh adduction and sensory loss of the medial thigh. What's unusual about the obturator nerve? As it descends from the sacral plexus, it actually passes straight through the psoas major muscle. What kind of an injury might cause an obturator nerve lesion? An anterior hip dislocation. The next nerve that we're going to talk about is the femoral nerve. This nerve runs medial-anteriorly through the thigh and subsequently innervates the muscles of the anterior thigh. These primarily include the quadriceps muscles, which do what? Leg extension and straightens the knee. It also innervates some of the accessory flexors of the hip, namely sartorius and the pectineus muscles. If you lose innervation provided by the femoral nerve, what might you expect? Difficulty with flexion and leg extension. What about a sensory deficit? Yeah, of course, on the anterior thigh and medial leg. How is the femoral nerve injured? Imagine someone in a horrible car crash with a pelvic fracture or other trauma to the pelvis. Let's do the next two nerves together, in part because they both originate off the sciatic, but also because their motor and sensory attributes are almost entirely mirrored. When you think about the common perineal nerve, also called the common fibular nerve, you should think about the fibula, which lies laterally in the leg. This nerve provides innervation to the muscles of the lateral leg and also the dorsal surface of the foot. What do the muscles of the lateral leg do? They pull the lateral side of the foot out, or evert the foot. When you think about the tibial nerve, you should think about the tibia, which lies medially in the leg. This nerve provides innervation to the muscles of the medial and posterior lower leg, and also the plantar surface of the foot. What do the muscles of the medial leg do? They invert the foot, as well as allow a person to plantar flex, or push their foot down like on a gas pedal. You can use the memory aids PED and TIP, to help you remember the functions of each of these nerves respectively. PED is for perineal everts dorsal, and TIP is for tibial inverts plantar. If you look at the motor and sensory deficits for the common perineal and tibial nerve, they match the function and paths of the nerves exactly as we've already discussed. The only thing we haven't talked about is the gait deficit that occurs with injuries to the common perineal nerve. When people walk, it's important for them to keep their foot dorsiflex, or it would either drag along on the ground or flap on the ground. This is often referred to as foot drop, and it's a relatively common lower limb pathology. What autoimmune disease is most likely to cause foot drop? Yep, it's multiple sclerosis. One way the boards will like to test the common peroneal nerve is by presenting a patient with chronic compression over the fibula, like an alcoholic who sleeps on park benches. Don't automatically assume that this patient has a vitamin deficiency. His fibula is actually constantly compressing the common peroneal nerve, giving very specific distributions of tingling and numbness, which is not how a vitamin deficiency would present. And also beware the woman who crosses her legs for hours on end. This is another way the boards will get at the common peroneal nerve injury. The two final nerves we'll look at are the superior gluteal and inferior gluteal nerve. What is the primary function of the superior gluteal nerve? To abduct the thigh. You can think about it as also stabilizing the hip. This is illustrated by the Trendelenburg sign, noted when a patient stands on the opposite foot as the nerve injury. When they do, their hip drops because the body can't keep the pelvis level, even as their weight shifts. So, if the right hip drops, which side is the nerve lesion on? It's on the left side, which is failing to abduct the left hip to keep the pelvis level. Patients with a posterior hip dislocation may present with subsequent superior gluteal lesion. Inferior gluteal nerve injuries also occur with posterior hip dislocation, but are different altogether because this nerve innervates the gluteus maximus. The primary responsibility of this muscle is extension of the hip, which is not a function used explicitly by people on a day-to-day basis. So how do patients notice? They have difficulty pushing the leg downward. This makes it hard to jump, climb stairs, or even rise from a seated position. Flash quiz. Anterior hip dislocation may mean injury to which lower extremity nerve and would cause which motor deficiency? The obturator, and it might cause loss of thigh adduction. As far as names of nerves and arteries, there's good news and there's bad news. For the most part, nerves and arteries that run together are named together. That's the good news. The bad news is that there are always some exceptions, which we're going to go over now in this section on neurovascular pairing. What nerve and artery run through the axilla along the thorax? The long thoracic nerve and the lateral thoracic artery. Don't get the long and lateral confused. There are a couple different locations along the humerus where the neurovascular pairing is named differently. Where is the surgical neck? Good. It's right here. The anatomical neck is right along the humeral head. What nerve and artery run here? The axillary nerve and the posterior circumflex artery. Okay, where does the radial nerve run? In the radial groove, at the midshaft of the humerus. What is the artery that runs with it? The deep brachial artery. Okay, in the cubital fossa of the distal humerus, we have the median nerve. The median nerve runs with the brachial artery here. And what about in the leg? What nerve runs with the popliteal artery? The tibial nerve. As a tibial nerve extends distally and meets the ankle, what artery does it course with? The posterior tibial artery. Why is it called the posterior tibial artery if it wraps around the front of the ankle? Because initially it starts out behind the tibia, a little bit more proximally. Okay, there you go. That's what you need to know about neurovascular pairing.